Systemic sclerosis and systemic lupus erythematosus both are multi-system disease. It affects variety of organ systems in our body. But systemic sclerosis is more of a sclerosing disease. Sclerosing means more of fibrosing disease. And SLE is inflammatory disease. Inflammatory disease. Both are autoimmune mediated, but here there is a lot of inflammation due to B cell, T cells, both B cells and T cell mediated. But here it is primarily fibrosing than inflammation. Inflammation is also there, but here what happens that directly, even there is no inflammation, directly fibroblasts starts laying down collagen. So fibroblasts start laying down collagen in the skin, in the lung, in the myocardium and other organs as well. So it is more of fibrosing than inflammatory disease, but there is inflammatory component as well. So let's start with what organs are involved in this condition. So first is a skin. In a skin, due to increased collagen deposition, actually the tensile strength, the looseness of the skin that we have like this and the opening of mouth, due to this is due to collagen in the skin, in the dermis. But when there is excessive collagen deposition, when there is in the dermis and there is fibrosis, what happens that this tightness occurs everywhere in the skin. Generally this starts like a distal to proximal distribution. Like first it affects the distal, then it goes to the elbow, then starts ascending upwards. So there, based on that, it is of two types. Let's suppose a patient has involvement in globe and stocking pattern, like here in the lower legs and in the arm. But this portion is spared, upper arm, thigh and trunk. This is called limited systemic sclerosis. But if trunk is involved, if proximal limbs are involved, then we call diffuse systemic sclerosis. So in the skin there is collagen deposition, not only collagen but excessive heavy collagen deposition, and due to that induration occurs. There is abnormal vasoreactivity. When I dip my fingers in cold water or when I am exposed to cold temperature, what happens that the arteries constrict, because you know that cold constricts and hot dilates the blood vessels. So normally what happens that due to cold the arteries constrict, the tips of the arterioles capillaries constrict on exposure up to the cold. This is normal phenomenon. But it is not severe enough to impair the circulation of the distal tissue. But in systemic sclerosis, what happens that these vessels are sclerosed. There is obliterative arteriopathy. Obliterative arteriopathy due to proliferations of this tunica intima, tunica media. So this, due to that there is narrowing of this blood vessel. So the blood, the small capillaries, arterioles are already compromised, and in top of that if you expose it to cold, what happens that it further compromises the circulation, and then there can occur ischemia, and that ischemia can lead to ulcer, necrosis of the tips of fingers, because you know at tips we don't have any collaterals. So when there is occlusion, it can lead to necrosis. And initially patient have Raynaud phenomenon. So what is basically Raynaud phenomenon? When you dip in the cold, initially there is whitish, pallor. Finger becomes white, then bluish, then red. Why it occurs that when you suddenly expose to cold, then there is sudden vasospasm, and due to that blood is suddenly cut off, so it becomes white. Like when you milk your finger like this, you can see it becomes white. But as you take it out of the cold temperature, then flow starts to regain. So initially, due to vasospasm, the cells are deoxygenated. So due to deoxygenated, high concentration of the deoxygenated blood, you can see cyanosis, bluish discoloration. But when the circulation fully returns, then it becomes red. So there can be three phases. Initially pallor, then bluish discoloration, then after circulation resumes, then rubor or redness. So this is initial phase, and this is abnormal vasoreactivity due to obliterative arteriopathy. You can also get this in systemic lupus erythematosus, in other connective tissue disease. Why? Because there is also inflammation in the small blood vessels, in the capillaries, and due to that there is abnormal vasoreactivity in those other autoimmune conditions as well. If you see with ophthalmoscope on these nail beds, in normal person you can see the normal capillary loops. But in patients with systemic sclerosis, what happens that there is already distortion of this capillary architecture. So there can be either over proliferation, giant capillaries, because there is occlusion in the distal capillaries. Due to that there is over proliferation occurs. So there can be giant capillaries, or there can be micro hemorrhages due to leakage from these capillaries, RBC leakage due to damaged capillaries, or what can occur that there can be absence of capillaries. When those are completely sclerosed, fibrosed, you won't see capillaries. So you can see the capillary health with ophthalmoscope at the nail bed. So where are the places where we can see capillaries directly? One is retina with ophthalmoscope, and another is at nail bed. We can directly visualize capillaries. And another is when there is telangiectasia, you can see capillaries on the skin. But telangiectasia is abnormal. If there is excessive telangiectasia is also seen in systemic sclerosis. Why does telangiectasia occur? Because of this small vessel disease, there is, due to compensate that, somewhere increased dilatation occurs. So that is called telangiectasia. And in the skin blood vessels, these microcirculations are compromised. So there is a stagnant blood flow, or blood flow is not that much good, or sluggish blood flow. So due to that you can see libido reticularis on the skin. This libido reticularis. So libido reticularis, telangiectasia, these suggest that the circulation in the skin is not good. So this is about skin features. Now let's talk about renal system. In renal, let's assume this is afferent arteriole, this is the capillary, and this is the efferent arteriole, and this is the nephron. This is the loop of Henle. It is going like this, opening into collecting duct, and this efferent arteriole comes alongside the tubules and supplying the tubules. These are called peritubular capillaries. So these capillaries are supplying the tubular epithelial cells. In SLE, what happens that there is immune complexes in these capillary lobes, immune complexes. So there is inflammation of the glomerulus, and these immune complexes also leaks here, and also incites immune complexes on this immune complex reaction in the subepithelial side, and since there is also immune complexes in the peritubular capillaries, so it also causes inflammation of the interstitium. So there is inflammation of the glomerulus also and interstitium also. So inflammation of the glomerulus is called glomerulonephritis. Inflammation of the interstitium is called interstitial nephritis. So there is inflammatory component. In systemic sclerosis, what happens that, let's assume this is efferent and this is the capillaries and this is the efferent arteriole. So there is obliterative arteriopathy. There is proliferations of the intima. Walls are proliferated in this condition. So in the capillaries, arterioles, efferent arterioles, everywhere there is proliferations of this intima and there is narrowed circulation. So there is already narrowed circulation in the renal, in the kidney, especially in the small vessels, these arterioles, capillaries, and on top of that, if there is so many insults, either it may be due to drug or like a steroid or any other or some unknown factors, what happens that since there is narrowed circulation, so GFR is low here. So macula densa in the distal convoluted tubule senses that the perfusion is less. So it gives auto feedback loop to secrete more renin, and what it does that RAS is activated, aldosterone is more. Due to that, sodium water retention occurs more. So and on top of that, if patient takes prednisolone in high dose, what happens that it also causes more sodium water retention, and there is already sodium water retention occurring due to this phenomenon. So patient may have accelerated hypertension. Or other risk factors of accelerated hypertension are like if you see patients with diffuse fibrosis of the skins or palpable tendon friction rubs, what happens that if there is diffuse fibrosis, you see these tendons are surrounded by tendon sheaths and those are maintaining the cushions. For example, I am doing like this, so these tendons are providing the cushions and I am able to comfortably smoothly do it. But when those sheaths are fibrosed, due to fibrosis, this smoothness is lost. And you can feel the rub when patient closes or do like this. Wherever you have tendon like Achilles tendon or here in hands, you can feel the rub. It means that fibrosis is extensive. And this is also one of the risk factor of the renal crisis, which suggests that fibrosis is also extensive in these capillary beds. That's why patient is at high risk of accelerated hypertension. And other risk factors are like if patient has antibody against anti-SCL70, this is called topoisomerase antibody, or antibody against RNA polymerase 3. So in these groups of patients also there is high risk of renal crisis. And due to this compromised circulation in these small vascular beds, what happens that there is disturbance in the blood flow and this leads to microthrombus formation. You know that with virchotriad, if there is disturbed circulation in any part of the blood vessels, it starts to form thrombus. So microthrombus may form, and wherever there is microthrombus, whenever the platelet travels through this route, then platelet sticks there, and it makes big thrombus. Ultimately it compromises this, might compromise this circulation. And if it is blocked, what happens that this is supplying the tubules, so these tubules also do not get blood supply, then these tubules also die because of the deprived of oxygen and glucose. So ischemia also can occur. And other conditions what can occur that due to this small thrombus in multiple capillary beds, whenever RBC travels through this, RBC also get hemolyzed. So hemolytic anemia can occur. Hemolytic anemia can occur due to platelets adhering to their thrombocytopenia can occur. And when there is ischemia is extensive, when it is damaged, the tubules starts to die, then creatinine can rise. So this thrombotic microangiopathy can be confused with the scleroderma renal crisis. If you see thrombotic microangiopathy, then you have to do plasmapheresis, because plasmapheresis saves lives in thrombotic microangiopathy. But in scleroderma renal crisis, you don't need to do plasmapheresis because that don't help. Why that don't help? Because the problem is in the narrowed circulation. In the arterioles, capillaries, there is no antibodies that you can filter it out. The problem is this narrowed circulation. So you have to give ACE inhibitor that blocks the RAS, because it is the problem due to RAS activation. So you have to block the RAS with ACE inhibitors. Or if ACE inhibitors does not work, then you have to add ARBs, or not even helping that, you have to add calcium channel blockers. But generally ACE inhibitors work because this is due to overactivation of RAS. Here also you can get thrombotic microangiopathy because here is also inflammation, glomerular inflammation. So when there is disturbed rheostasis of the blood flow, then it causes microthrombus formation and platelets starts sticking here. And whenever the RBC travels through that, it gets hemolyzed, hemolytic anemia, thrombocytopenia. And due to those multiple cytokines release, patient may have fever, and when patient has thrombocytopenic purpura, then we have to do plasmapheresis. So this is about renal manifestations. Now let's talk about pulmonary manifestations. So in lung, there can be diffuse parenchymal lung disease in both conditions. In SLE, systemic sclerosis as well. So what is this diffuse parenchymal lung disease? You know that these alveoli, these trachea branches into bronchus, then multiple bronchioles, and ultimately it gives rise to respiratory bronchioles. That respiratory bronchioles further divides into multiple alveolar duct, and in each alveolar duct there are opening of multiple alveoli. So the inflammation of these respiratory bronchioles, alveolar ducts, alveolus, this we call diffuse parenchymal lung disease, because this is the respiratory zone. Here gas exchange occurs. These are only the conducting zones. Here only conduction of the oxygen carbon dioxide occurs, and their mucous cells produce some mucus, those humidifications, but the gas exchange in this zone. And if the problem is in the gas exchange, patient develop hypoxemia. In this interstitium, there are subinterstitial tissue, and in a systemic sclerosis, what happens that fibroblast starts laying down collagen here. And when there's multiple fibroblast starts laying down collagen, what happens that it causes fibrosis of this. And when there is fibrosis, it means that alveoli are damaged. It won't be able to exchange gases. So in diffuse parenchymal disease, there is not just involvement of alveoli, but alveolar duct, respiratory bronchioles, and sometimes these terminal bronchioles can also be involved. So let's talk in detail about this diffuse parenchymal lung disease. So there can be two patterns of this condition. One is called fibrosing, another is inflammatory. So why do you need to differentiate fibrosing versus inflammatory? Because if there is fibrosis, then anti-inflammatory drugs won't work, like these steroids, cyclophosphamide, mycophenolate that we use to kill those B cells, T cells, to control the inflammation. There is no role if there is already fibroblasts are laying down collagen. There are no B cells, T cells, to whom will you kill? You have to kill either a fibroblast with tyrosine kinase inhibitors like nintedanib, pirfenidone, you have to use like that. But if there is inflammatory component, B cells, T cells are there, you can kill those B cells, T cells with cytotoxic drugs. That's why I have to differentiate this, whether this restrictive lung disease, diffuse parenchymal lung disease is fibrosing pattern or inflammatory pattern, or it is both, or which is more predominant. So based on that, they have classified into UIP pattern and NSIP pattern. In NSIP pattern, there is inflammation component more, but fibrosis part may also be there, plus minus fibrosis, but here it is fibrosis. If you see the CT scan of UIP, let's suppose these are the lungs and this is the mediastinum. So there is honeycombing, subpleurally located. These are small honeycombs. So what is this honeycombing? Honeycombing means those alveoli, respiratory bronchioles, alveolar ducts, all are fibrosed and conglomerating into honeycombs. If you see honeycombing, you should suspect that it is fibrosis. So there is honeycombing, and due to this fibrosis, what happens that if there are bronchi here, so what does fibrosis does? It pulls the bronchi towards it. So it pulls it towards it. Due to that, there can be bronchodilation, and that is called traction bronchiectasis. So since the fibrosis is giving traction to the bronchus and causing dilatation of the bronchi, we call traction bronchiectasis. So if you see honeycombing traction bronchiectasis, you should suspect UIP pattern or fibrosing variant of diffuse parenchymal lung disease. But if you see the pattern, like there is ground glass opacities, even it may be subpleurally located, because you know that towards the mediastinum there are more bronchioles, and here peripherally there are more alveoli. That's why these involve subpleural locations. So if you see in these subpleural locations either ground glass opacities and no honeycombing, reticulations, ground glass opacity, this suggests there is more inflammatory component, and there anti-inflammatory drugs will work. So you can use steroids, mycophenolate, cyclophosphamide, azathioprine, like those drugs. That's why you need to differentiate between UIP pattern versus NSIP pattern, and this can occur, both pattern can occur in systemic sclerosis as well and SLE as well. In these both conditions, there can be pulmonary hypertension as well. So, but pulmonary hypertension is more in systemic sclerosis than SLE. If you see the prevalence, pulmonary hypertension is more in systemic sclerosis. So, why does pulmonary hypertension occurs in systemic sclerosis? One, I told that ILD is there. Since there is diffuse parenchymal lung disease, there is no gas exchange. Gas exchange is hampering, and you know that in pulmonary circulation, when there is hypoxia, blood vessels constrict there, because lung tells that, oh, there is no good oxygen exchange, so let's divert the blood away, so that wherever there is good oxygenation, we do circulation there. That's why blood diverts there. So due to that, there is vasoconstriction, and then right ventricle will have difficulty pumping against those vasoconstriction, because there is obstruction ahead, and that's why the pulmonary artery pressure rises to force the blood towards that, because there is obstruction, and to prevent to bypass that obstruction, right ventricle pumps hard, and that is transmitted to the pulmonary artery. That high pressure right ventricular systolic pressure is transmitted to the pulmonary artery, and pulmonary artery pressure rises. So in ILD, due to ILD, there can be increase in pulmonary artery pressure, or even this pulmonary artery pressure can rise due to systemic sclerosis itself, because in systemic sclerosis there is intimal proliferation. Due to this proliferation, what happens that these vessels gets narrowed. Let's suppose this is the pulmonary artery and this is going towards the lung, and here is the capillary, and here it is returning back like pulmonary vein, let's suppose. So since there is fibrosis here, what happens that this is rigid pipe. So initially it was compliable pipe. Whenever in the blood was flowing in the pulmonary artery, it was able to compliant, it was able to expand, accommodate. But when it is rigid pipe, when the blood flows, it cannot expand. So automatically the pressure inside the pulmonary artery rises. This is called pulmonary artery hypertension. There is no obstruction ahead, unlike diffuse parenchymal lung disease. But the problem is here itself. Or what I told that another cause can be, since the problem is also here due to obliterative arteriopathy in the small vessels. So sometimes this microthrombus forms in the pulmonary circulation, that we call chronic thromboembolic pulmonary hypertension. So either due to primary problem in the pulmonary vessels, or due to diffuse parenchymal lung disease, or due to CTEPS, or due to left heart disease, also here pulmonary hypertension occurs. So why left heart disease occurs in systemic sclerosis? Because fibrosis also occurs in the myocardium, in the pericardium. So when fibrosis occurs, there is left ventricular diastole cannot occur properly. Then left ventricular diastolic failure occurs. So the left ventricle is not able to accommodate the blood. So those bloods will back up in the lungs, and this backup will give resistance to the blood flow from this right ventricle, and that raises the pulmonary artery pressure. So multiple mechanisms of rise in pulmonary artery pressure in systemic sclerosis. So why do you need to differentiate whether it is the primary problem, or whether due to left heart disease, or whether it is due to CTEPS, or whether due to other problems? So what is the implications of that? Because in treatment, whether we give vasodilators to this circulation or not is determined by that. So what are the vasodilators of these pulmonary circulations? Like endothelin antagonist, bosentan, macitentan, ambrisentan, centan, those endothelin antagonists. Other is phosphodiesterase 5 inhibitors like sildenafil, tadalafil. Another is nitric oxide. If you increase the nitric oxide in those endothelial cells, it also helps dilate, like soluble guanylate cyclase stimulator. Those produces nitric oxide like riociguat. So in which condition do you give those? If the problem is, let's suppose, is in this, the problem is not here, but the primary pathology here, the proliferations of these vessels. So in these conditions, what happens that if you give these dilators, then it helps facilitate the blood flow, and it goes like this. But let's suppose if this is due to left heart disease, and due to that the blood is backing up here, and in this condition if you give pulmonary artery vasodilator, then what happens? The problem obstruction is here, and to bypass that obstruction, to overcome the obstruction, it is raising compensatorily the blood pressure in the right ventricular systolic pressure that is being transmitted to this pulmonary artery. So heart is trying to move the blood towards the left side of the body or left side of the heart, but you are decreasing the pulmonary artery pressure, so that will worsen the condition. Or let's suppose the problem is here, due to diffuse parenchymal lung disease, there is vasoconstriction here in these vessels. There is vasoconstriction due to diffuse parenchymal lung disease, and problem is not here. Problem is not here. It is good, but here there is obstruction due to the vasoconstriction due to diffuse parenchymal lung disease. In this condition, if you dilate this, what happens? Due to this obstruction, this right ventricle is compensating to overcome this obstruction, and if you dilate this, it will worsen, because the right ventricle is compensating to the forward obstruction. That's why it is raising its blood pressure in the pulmonary artery. And if you dilate this, or if you lower the pulmonary artery pressure, it will be deleterious. But let's suppose there is already right ventricular failure, RV failure. In that condition, you can use this dilator here, because here the right ventricle do not have capacity to pump. There it has already failed. No, initially it had capacity, so it was pushing the blood in the pulmonary artery to overcome the obstruction. But it has tried hard, and for a long time it has failed. Right ventricle is failed. Now if you give these dilators here, there it will be benefit rather than harm. Initially, when right ventricle has not failed, if you cut off the compensation done by right ventricle, patient will have deterioration. But if there is already failed, then you can dilate this, and that improves hypoxemia. So that is about pulmonary hypertension. And now let's talk about GI involvement in systemic sclerosis. In GI, this fibrosis occurs everywhere. So this is also occurring in the gastrointestinal tract. So fibrosis occurring in this esophagus, fibrosis occurring here in the sphincter. So what happens that due to this, their peristalsis is decreased. Here what happens that this contractile strength property is decreased, and due to that there can be GERD. Due to fibrosis of this gastric, what happens that gastroparesis occurs. Gastroparesis occurs. And you know that there are variety of chief cells, parietal cells, those secretes intrinsic factor for absorption. So there is fibrosis, those cells architecture are also disturbed. So vitamin B12 deficiency occurs. If this fibrosis occurs in this small intestine, this cannot absorb the nutrients, so patient have malabsorption, diarrhea. So see, fibrosis occurs from mouth to anus. So this whole intestine is fibrosed. So the motility, peristalsis is decreased. There can be malabsorption.